Okay, let me go back to the beginning. Okay, so Sarah Lynn is our first VSIM case. We'll begin assignment, and this first page is suggested readings. So SBAR is situation, background, assessment, and recommendation. Okay, so it's a format for how we organize information that we need to give in a handoff report, or like calling the physician. It helps us make a plan for what to say and figure out what is a good thing to recommend, how we think that things ought to go, what we'd like to see the doctor do, but we're not telling them. We're offering information. Okay, so SBAR, situation, background, assessment, and recommendation. And you'll be using this format in clinical to do your documentation. Okay, Sarah Lynn is an 18-year-old Asian female who presents to the ED with a history of nausea, vomiting, and severe abdominal pain. Blood work has been drawn, and the patient's been diagnosed with appendicitis, which was confirmed by a computed tomography scan, which is a CT scan. She's scheduled for an appendectomy later today and has received IV antibiotics in preparation for surgery. That's the situation. Background: Sarah was healthy prior to this event and has never had any surgeries. Assessment: Sarah is alert and oriented to time, person, and place, appropriate for age. Heart rate and rhythm are regular. Lungs are clear to auscultation. Oxygen saturation is 96% on room air. The abdomen is slightly distended and tender to light palpation with rebound tenderness present. Sarah had pain medication of 5 milligrams of IV morphine 1 hour ago for a stabbing pain of 10 out of 10 in her right lower quadrant. Recommendation is to please perform an abdominal assessment and reassess her pain, performing a focused pain assessment. So what this particular health assessment case is mainly about pain assessment, which is what you're going to be doing not this week in not next week in clinical, but the next week. Okay. So this is suggested reading. So if you look here, let's look. Here's the model for SBAR. And this is in your textbook. It's going to a place in your textbook. Okay. Excuse me, I'm going to sneeze.
Bless you.
Thank you. So this is the handoff summary. Handoff is when you're reporting to another person who's going to take over caring for a patient that you've been taking care of. And so this is information about doc recording, and then here is information about SBAR. So you can look this up. Anything on the suggested reading page that all of these things are related to the kind of care that Sarah Lynn needs, and what and things about what you should look for, and how to do her assessment. Okay, let's see what else. Reassessing and documenting pain, and of course this is going to go back to the textbook. So the pain experience, how the pain is affecting the person. Um, this is just information about assessing pain. Okay, and that's stuff that you'll want to know when you're working on your clinical for the week after next. I think there's something in here about, yeah, okay. So this is about assessment, okay, the first section. And then diseases and conditions. It tells you about appendicitis and peritonitis. So appendicitis is an infection of the appendix itself, but if the appendix ruptures, the patient's going to get peritonitis. So if you were to read through this information, that would give you a lot more information about how to teach your patient, about what to expect, and how to know what you're observing for. Pharmacology, this is about the morphine that you're going to give her for pain. Patient handouts, this is patient information about appendicitis, and it's from all of these things are from the Lippincott Advisor. And then the procedures, assessment techniques, and pain assessment. These are actual, not checklists, but here, let's just look at it. Just information about the physical assessment, the techniques of assessment, and the equipment that you might use, preparing the equipment, implementation, inspection, palpation, identifying percussion sounds. This information is here. You can see that she's doing indirect percussion there. This is blunt percussion here, checking the CV, the costovertebral angle, and then auscultation, and then a whole bunch of references if you're interested in that. Then pain assessment. So introduction, equipment that you might use, and implementation. Then there's information about the different kinds of pain scales where a person can, you can ask, what's the number between 0 and 10? What is your pain right now? And that's a good way to start off, give the pain medicine after you find this out, and in a little while go back and ask them if the pain is improved or not. And usually, like at the when a person's first admitted, depending on what their problem is, I might ask them, how much, what level of pain would you have to be at before you wanted to take pain medicine for it? And that's how we know, that gives us information about how the person tolerates pain. And here's the visual analog scale where they mark. They just put a mark here about how much pain they're having. This is the FACES pain rating, and this is for a little kid to pick out how they feel, how much it's making them hurt. This might be appropriate for an elderly person as well. I know when my dad, he had Alzheimer's disease, and when he broke his hip and he was in the emergency room, everybody who came in would ask him on a pain scale of 0 to 10, how much pain are you having? And he had no idea what they were talking about. And he knew he was hurting, but he didn't know how to think about 0 to 10 and how much pain he was having, and fitting it into that picture that they were trying to get of how much pain he was having. So special considerations about pain that you need to know is if your patient is like an infant, a newborn, or a little kid, they don't have language. They can't tell you. And so you have to look at body language. You have to look at the tension in their body. And with a little baby, and especially, the younger they are, the more important this is, the sounds that they make, the sound of their cry. As they get in more and more and more distress, their cry gets higher and higher and higher pitched. And that's a very sad sound too, when a little baby is crying like that. But somebody who is hearing impaired or vision impaired, you have to take do special procedures to be able to find out the information you need to find out from them. And somebody who's cognitively impaired, or they can't speak to you for whatever reason, you have to show them pictures or in some other way, figure out how to find out. A lot of times people who are like somebody with Alzheimer's, they get more restless, they get kind of agitated and irritable, they can't settle down, and when they're having pain, because they don't have the words anymore to say what's happening to them. And always remember this, that if pain is left untreated, it's going to have negative consequences for a person, including multi-systemic complications and the development of chronic disabling pain. That's going to affect a person's well-being and quality of life. And it could cause them, they don't like going to work. They may lose their job. They're not going to do as good of a job, probably. They might limit their mobility, and that increases the risk of complications like deep vein thromboses and something else to remember about pain. And we'll talk more about it when we talk about it in class. But about pain, the signs and symptoms of pain are different for acute pain versus chronic pain. So our patient, Sarah Lynn, she's having acute pain. Okay, it's probably going to affect your sympathetic nervous system. Her heart rate is going to be probably faster than normal a little bit. Her blood pressure might be high. She might be restless. She might be moaning and holding her belly. But for chronic pain, somebody who's been in pain a long time, their sympathetic nervous system doesn't respond in the same way. And the major symptoms you're going to see, if they were to start having more pain, like came to the emergency room and said they were in more pain and asked for help, their blood pressure is going to be fine and their heart rate is not going to be rapid. The chronic pain causes because the sympathetic nervous system is acting the same way over a period of time of having chronic pain. And their signs basically are depression and withdrawal. You're not going to have the sympathetic nervous system changes. Okay, so you've got all of this information to look at to find out about the patient that you're going to be assessing on this particular VSIM. Then you've got a pre-simulation quiz. And so from the information that you collected about this patient's situation and about from the suggested readings, hopefully this quiz is going to come up. There's usually around 10 questions. And you can answer them over and over if you want to get the best grade that you can, but you need to do this section. You need to do the pre-simulation quiz. So you use the arrow to go to the next question, and you can answer them over and over again if you need to. After that, go to the health assessment itself. launch the simulation. And here's your patient. And here's basically the same information that you got in your SBAR in the introduction. Okay, here's some helpful tips. You can play a scenario as many times as you'd like to improve your efficiency and your score. In the simulation, you have to click on the patient handoff icon that's at the bottom of the screen. You can stop an active action such as attaching a pulse oximeter by hitting the button again. This is important, you've got 40 minutes to complete the simulation, but you can pause it by clicking the pause button. Read through all of the helpful tips as you get started, and it gives you information about how to use the buttons. Okay. We're going to go see this patient. Okay, this is the patient's electronic health record. This is the SBAR here. Here's some demographic information about her. Okay, there's also demographics up here at the top. It's like a real electronic health record like you use in a hospital. It's also like DocuCare that you're going to be using in a couple of weeks. So the patient's name, her admission date, gender, height and weight, date of birth, immunizations up to date, and allergies, no known allergies. Her admission diagnosis is appendicitis. And DX is one of the abbreviations that you need to learn. It means diagnosis. Then the patient log, and this is like a transcript of all the things that you've done. Diagnostics. You've got some. You might get blood gases. You do have a blood analysis. It's a CBC. Not actually a whole CBC, it's just a hemoglobin and hematocrit. It's what they absolutely have to know before they take a person to surgery. Okay, hemoglobin and hematocrit are within normal limits, so are the platelets, and white blood cell count is very high, which is part of the picture for diagnosing appendicitis. Down here you've got electrolytes. Potassium is 4, which is within normal limits. Sodium is a little bit high, and that probably has to do with dehydration. Okay, when you don't have as much fluid, this is going to be the sodium is going to be a little more concentrated. We'll be talking about that in patho on Thursday. Creatinine level and the BUN. Creatinine and BUN are giving us information about the function of the kidneys. So creatinine is okay, BUN is okay. The HCO3, this is it's one of the electrolytes that we measure. This is 23 is okay, and your chloride is 106. And it kind of varies with the potassium and sodium, but then we didn't need any hepatic function studies. We've got glucose. A random glucose is 102. That's good. Whenever somebody, a young woman of childbearing age comes in with abdominal pain, they always do a pregnancy test and a urinalysis. Because an ectopic pregnancy causes a lot of the same symptoms as appendicitis does. And a UTI can cause that kind of abdominal pain as well. Here's coagulation studies, and we'll be talking about that in patho. And then they did a type and cross match for blood type in case she needed blood during surgery. And that's all. Sometimes when somebody's having abdominal pain, they'll do a stool sample, abdominal pain and diarrhea especially. And they'll do a stool sample and look for C. diff, which is a major problem for a lot of chronic patients. and stool for ova and parasites. So they're looking for signs of worms. So always look over all your diagnostics and just kind of start getting used to what things look like. And we'll be learning about all these things in patho. Clinical observations. You can chart the patient's heart rate, temperature, oxygen saturation, and blood pressure on this page. You can chart it yourself. The medication chart goes by her doctor for orders. She's got her, she's already had her IV antibiotic. She's got some PRN medication. Ondansetron is for nausea and morphine is for pain. And they just gave her that at 6:45. And this is her IV fluid that she's getting continually, 125 milliliters an hour. And the a bag is usually 1,000 milliliters, so 125 milliliters an hour is an 8-hour bag, and have to be empty at the end of 8 hours. Radiology, she hasn't had any radiology, even though she had a CT scan of her abdomen. The report isn't on here. Here's her admitting orders. And it's good for you to take time to read through all the admitting orders for all of your patients and make sure that you understand the words. This is the medical terminology part, okay? And abbreviations, or NPO means nothing by mouth. It's actually, the Latin terms are non per os. Non per os. Let me write that. That means nothing by mouth, and we just abbreviate it NPO. And how often we're supposed to get her vital signs and her O2 saturation, that's the pulse oximetry. If her pulse ox or her O2 saturation goes below 92%, we're supposed to put oxygen on by a nasal cannula. She's going to have a continual IV. She already had her IV piggyback antibiotic. The ondansetron, that's the same drug as Zofran, that you might know it by that name, and then morphine. And these are the labs that have been done, the CT scan, and call orders. So anytime or whenever somebody's admitted, the doctor will probably put some call orders, and this means that we're monitoring for these things. And if the patient manifests any of these things, that we're supposed to call the doctor and inform the doctor so that they know that something is going wrong and needs to get fixed. So systolic blood pressure lower than 90 or greater than 140. Diastolic blood pressure lower than 50 or greater than 90. So we'll be monitoring the blood pressure every 4 hours. Respiratory rate lower than 8 or greater than 25. Okay. Oxygen saturation lower than 92%. So if we find that her oxygen saturation is this low, we put oxygen on and call the doctor to notify him. Temperature greater than 38 degrees centigrade, which is 100.4 Fahrenheit. This is really, really important for a surgery patient. Whatever the doctor says about, call if the temperature gets to this, it's really important for you to call. What they'll probably do is order blood cultures. They might have you do some kind of a wound culture or blood cultures or a culture of some kind to evaluate. They don't want you to give anybody, Tylenol or ibuprofen or anything to bring a temperature down, and they won't order any more antibiotics for this person until they see what might be the cause of this problem, of the fever. And then you've got a place to record intake and output. And this is on the agenda to talk about in patho too. Intake is going to be anything by mouth, or if she was to have an NG tube or a feeding tube, which she doesn't, we would put the intake here for IV intake and IV piggyback intake. So this is her total intake up to now, which it's just 8 o'clock, right? That's when we received her. And so at the end of the shift, we total up all of these, all of the intake, and we total up all of the output. So urine, a lot of times if somebody vomits, we can catch it and measure it. We can give them a basin to throw up in if they're sick, and measure it. NG tube, nasogastric tube, any drains that they might have after surgery. And we record it all here and add it up at the end of the shift. And we have to compare the intake to the output. We want our patients to have, pretty much the same intake and output. We don't want them to be retaining fluid, and we don't want them to be putting out more output than they're taking in. Well, if they were losing more fluid than what they're taking in, then they could develop edema. If they're putting out more fluid than what they're taking in, then they're going to become dehydrated. So we try to keep them in balance that way. Okay. So this is the electronic health record. You always need to look all through it and practice understanding what all the information here. Okay, and then we will go to evaluate the patient. So down here you've got, if you want to look at anything in the electronic health record, it's in this button. If we need to call the doctor about anything, we can use this button. And when we get finished with our evaluation, then we hit the patient handoff button. Okay, and we'll start off with safety measures, and you just tell the program what you want to do. I'm going to wash hands. She's washing her hands, and she's kind of slow, really. I'm going to introduce myself. Identify the patient. I'm going to ask about allergy. Okay, and you can put on if you want or not. Now we're going to go to communication. We are going to ask questions about, this is part of the health history, general survey, review systems. So these are questions that you can ask her to determine her orientation. Are you awake? What year is it? Can you tell me where you are? Can you tell me today's date? So we talked about that in our class this morning. And then past medical history. We've already asked about allergies. Do you take any medicines? Medications, medical problems? Are you a smoker? Current illness? How are you feeling? What happened? Do you have trouble breathing? Do you do any breathing exercises? When did you last have something to eat? Do you feel better now? Are you dizzy? Do you feel nauseated? Okay, those are questions that you can select. And then the pain assessment. Do you have pain? Does anything make the pain better? Does anything make it worse? Describe the pain. How would you rate your pain, and where does it hurt? Those are all aspects of the PQRST we talked about. And then if you want to educate the patient, and you should tell the patient about what you're going to do, your assessment steps, and talk to her about activity, safety, and fall risk. That should be some of the first things that you know, when you're introducing yourself, you need to talk to her about this. And then later on, you can go and talk to her about her diagnostics, you know, the tests that she's had done, and improving venous return, pain management, plan of care, range of motion exercises. So select what you want to ask her, and you don't have to ask her every single thing, but you need to pick out what's appropriate. And then interprofessional communication. Are you going to call the provider? Are you going to order a 12-lead EKG? Are you going to contact the lab or contact ultrasound? And that would be these things. You would need an order, a doctor's order for that. So if you had to call a provider about anything, you might get an order to do some of these things. Okay, and then we'll go to assessments, and let's examine upper arms to start with. This is where you measure the blood pressure. Okay, and that's what you would record on her vital signs record. And then inspect the skin, palpate skin. You need to do all of these things. And then when you examine the arms, you can check the pulse. Okay, and then you can inspect and palpate the skin and the joints and assess the mobility. And you can listen to the lungs, listen to the heart, assess the abdomen, examine the abdomen, palpate the abdomen. You can do light palpation. Check her emesis basin, because she said she was nauseous, and we gave her medicine for that just a little while ago. You can check on that. And then turn her around. Let's listen to her lungs. You can assess the skin, the hair sensation, palpate it. Okay, and then you will go down here and auscultate the front. But let me show you one more thing under intervention. I don't guess it's going to let me finish. Oh. Okay. Under interventions, I should have had her to sit up to be able to listen to her lungs. Okay. So here's position the patient lying, sitting, or high sitting. And if you heard any crackles in her lungs, which you might, you would encourage her to cough and see if that clears up the crackles. If we had started to give her oxygen, we would need to check the oxygen device. We might offer water and comforting the patient. Okay. And all the things that you do are going to be all the things that you've done, and I haven't done all the things that needed to be done, so I'm not going to have a good grade. But all of the things that you've done are going to be in this script. And it's going to give you information about what information about what you did and what you should have done. And on a detailed view, I should have asked the patient when she last had something to eat. I didn't scroll all the way down. I'm sorry about that. I forgot to do that. Ask the patient when she last urinated, when she had her last bowel movement. Those are all going to be under questions that under communication. And over here, you're going to have your main opportunities for improvement. So it's going to tell you what you really, really, really need to do different when you do this again. And you can, retry. You can continue and sign out, or you can retry and go over it again. But remember, it's going to sign you out after 40 minutes. So I know that that's frustrated some students who just kept on working. Where would we record all this? Julie, all of the things that you do are automatically recorded in the script. Now you can record her vital signs when you go to the electronic health record. You can record her vital signs. You might, if we measured the amount of her emesis, we could have written it in the output. Yes, do every assessment box, and you're going to do a complete physical assessment, but the focus is really on pain assessment. Okay, now I'm going to end this, and it's going to take me back to I almost don't want to push this button. Okay. Okay, so that was the simulation. Now you need to do a post-simulation quiz. And this will give you 3 grades. Okay, you'll get a grade for your pre-simulation quiz, a grade for your health assessment, and a grade for the post-simulation quiz. So after you finish your simulation, then be sure you go back and answer this. And then right now, let me show you these, but I'm not going to ask you to do this right now. So you can launch DocuCare. You won't need to do that for Sarah Lynn. That's going to be on an assignment in the future. Okay. But that's where you'll be doing more documentation. So, but these are questions that, especially here, document your findings and patient's reactions related to the focus assessment of her current pain status. These are, sometimes I have students to answer these questions, but for this simulation, just ask the questions of yourself and see what you think. You don't have to write anything down, but go through it, and then go through the guided reflection questions. And these are like, what do you believe were the priorities for the simulation? What do you think went well? What did you do good? What issues did you come up against in the during the experience. And that's not about the patient, that's about you. What was it that you had to think about harder, or that you had to go back and do a few times to get it right? And then scenario analysis questions. What assessment needs did you identify? Discuss additional non-pharmacologic actions that might be appropriate for managing her pain. Pre-op teaching that she needed. So some questions to think about in specific for this patient. And so think about those things, but you don't have to write anything up for this assignment. Pardon me. On the next VSIM, we'll launch DocuCare and practice documenting on DocuCare, which is an electronic health record. Okay, any questions? This particular assignment for Sarah Lynn, excuse me, is due on January 31st at 10 p.m. That's a Sunday evening. And it'll give you a grade in your course point grade book. And it'll be a grade that I figure in with your Prep U and quiz grades. Okay. Other questions? Any questions? What do you think? Nothing? Yeah, it's if we stop in the middle of the procedure, does our time keep going? If you push the pause button, if you click on the pause button, then it'll stop your time. Okay, you have to click on the button again to start it again. Yeah, the VSIM is pretty cool, and it's a little bit different from Shadow Health. It's the same idea. You've got a VSIM patient, but you have to, well, you do have a script to follow to ask your patient questions. And whatever you say or whatever you type in is going to be on you're going to get a script that documents everything that you said or did, and on Shadow Health. So you'll get the same kind of information from that, and it also gives you a grade, and it also tells you if you're beginning or developing or proficient, and you need to do your Shadow Health over again as much as it takes till you earn a proficient grade. And Brooke asked, do we only have one accumulative 40 minutes? No, it resets when you retry. You have 40 minutes whenever you start over again. You can do it as much as you want, and the same with Shadow Health. All of the VSIM patients, well, you only have one patient, Tina Jones, but all the different systems that you assess, you can do it over and over again until you get the grade that you want. But if when you get proficient, you get 100% for it. Other questions? You can also redo the quizzes as much as you want to until you get the grades that you want. But whatever grades you get on this is what your grade is going to be. You have a chance for three grades for each VSIM, and each one can be 100%. And that would be 100 for that VSIM. Okay, are y'all ready to sign off? I think I've told you everything I know. Okay. Alrighty, well, I'll see y'all probably on Thursday then.